Good morning, everyone. I shall be talking on familial unilateral right-sided Brown syndrome in two sisters, a rare report from Indian population. In brief, Brown syndrome or superior oblique sheath syndrome, the eyes are tethered down by the tight superior oblique muscle. Most of the cases which have been reported are either sporadic or non-familial. Autosomal recessive and autosomal dominant inheritance with a reduced penetrance are seen. The congenital familial Brown syndrome has a rare incidence of 1 in 20,000 live births. So, first case, a 12-year-old female patient presented to our OPD with the complaints of outward deviation and the diminution of vision in the right eye, as informed by her mother. There was a similar complaints in the elder sibling. The best corrected visual acuity was 6/12 in the right eye and the 6/6 in the left eye. On examination, we could see there was in primary gaze there was 30-degree exotropia in the right eye and the left eye was hypertropic. On elevation, we could see the limitation of -2, and on the levo elevation, we could see the limitation of -4, and on the dextro elevation, we could see the limitation of -2. So there was more limitation in levo elevation. And on doing the prism bar cover test, we could find the 45 prism diopter horizontal deviation and 20 PD vertical deviation. And on the fundus photography, we could see the intorsion in the right eye. Second case, a 15-year-old patient, which was the sibling of the first patient, presented with a similar complaints like outward deviation and the diminution of vision in the right eye. There was similar complaints in the younger sibling. We could find out there was right-sided head tilt in this patient. The best corrected visual acuity was 6/6 in the both eyes, and on extraocular movements, we could find the 15-degree exotropia in the right eye, and the left eye was hypertropic. And on similar findings was seen, there was -4 limitation in the levo elevation, then -2 in the elevation, and in -1 in the dextro elevation. And on prism bar cover test, we could find the 30 PD vertical deviation and the 20 PD horizontal deviation. And on fundus photography, we could find the paradoxical intorsion in the left eye. So after doing the exaggerated guidance tendon traction test, which was strongly positive for superior oblique in the right eye, we made the diagnosis of familial Brown syndrome in both the sisters. So we performed in both the patients right eye 8 mm chicken sutures using double armed 50 polyester with bilateral LR recession, which was done 10 mm in the first sibling and the 8 mm in the elder sibling. Intraoperatively, after giving the traction, there was conjunctival recession was done in the superior temporal quadrant. We could locate the superior rectus muscle. Then we hooked the superior oblique muscle and we passed our first suture. And after passing the first suture, we took the mark of 4 mm and we passed the second suture. So a loop of 4 mm was created in between, and hence finally the 8 mm loop was created. Outcome, both the patients were orthophoric in the immediate post-operative period. There was the limitation of elevation and adduction improved in the right eye. The alignment was maintained till 3 months of follow-up. So multiple surgical procedures for the treatment of the Brown syndrome, which includes the sheathectomy as explained by Brown, tenotomy, superior oblique tenectomy, right silicone expander, suture tendon lengthening, Z tenotomy, split tendon lengthening procedure, and the chicken suture lengthening, which was given by Knapp in 1975. So favorable post-surgical outcome was achieved in both the patients with chicken suture. So to the best of our knowledge, this is the first report of familial Brown syndrome from India. Thank you.
That is a good presentation. In your presentation, you said post-operatively you could reach orthophoria. Are you sure you could reach orthophoria just by surgery?
Yes, ma'am.
Or is it orthotropia?
Yes, ma'am. The patient was orthophoric, ma'am.
Did you check the sensory elements, stereopsis and all, fusion and all?
Ma'am, the stereopsis was good in both the patients preoperatively as well. In the patient which had the AHP, she had the 60 seconds of stereopsis, stereocircles, and the younger sibling who had amblyopia in the right eye, she was having 4 seconds of stereopsis.
The second child, you said there was a primary position exo
Yes,
plus
sir.
a depression. Then it's not easy to believe that the patient had orthophoria. Okay, go ahead.
Can you describe how the guidance traction test is done?
Ma'am, this is different for the right eye and the left eye. Like if we are performing in the right eye, we have to hold at the limbus at the 10 o'clock and at the 4 o'clock position. Then we have to push the right eye towards the superior medial direction, and then we feel the resistance. And if it is tight, so we have a difficulty and we feel there is resistance. So that was strongly positive in both the patients in the right eye.
Actually, you have to retropulse.
That's
Yes,
the
ma'am.
important thing. You need to retropulse the
This
globe,
yeah.
and you have to actually tort it
Yes.
over the superior.
Yes.
But then also, these are very difficult cases. So to achieve a ortho, it is really very difficult. Whatever these cases are, whatever we do,
Yeah, ma'am.
even after doing chicken sutures, also there would be some limitation of
Yes, ma'am.
elevation in.
Ma'am, we didn't follow the patients after 3 months. Actually, she was both the sister was from very far away, so we had the follow up only till 3 months.
Thank you.
Thank you.
I would invite the next presenter, Dr. Meena Chembil, to present on Botox, a boon for acute acquired comitant esotropia, the epidemic during the COVID-19 pandemic.
Good morning, everyone. I'll be speaking on botulinum toxin, a boon for acute acquired comitant esotropia epidemic during the COVID-19 pandemic. It's not moving. Okay. As all of us know, acute onset ESO deviation is an ESO deviation which occurs suddenly in a previously straight eye, and there is no accommodative component which is usually associated, and no significant refractive error also. So initially, when we used to see an acute esotropia, the first thing that comes to our mind is some intracranial pathology, and definitely they go for a neuroimaging. And it was not that common a condition. But things changed. There was a dramatic change in our COVID pandemic time when the children were confined to their homes and their school were limited to mobile phones and tabs. And there was a dramatic change, and we could see a surge in the number of acute comitant esotropia cases. So our purpose of our study was to assess the clinical characteristics of these patients, and mainly to compare the efficacy of botulinum toxin over observation for a period of 6 months follow-up. So it was a hospital-based prospective interventional study, and it was done from 1st June 2020 to 30th June 2021. And the inclusion criteria were acute acquired comitant esotropia of at least 10 prism diopter or more for distance and near, with minimal refractive error, no history of prior eye surgery, and no ocular, organic, or other systemic problems. All the patients underwent neurological imaging. We didn't want to miss out on anything, and they were grouped randomly into Group A and Group B. And Group A were treated with injection botulinum toxin type A, 1 international unit for every 4 prism diopter, directly injected slowly at 1 centimeter behind the insertion point of the medial rectus muscle. And Group B was kept under observation. So there was a total of 16 patients, 8 patients in each group, and they were age matched, and females were more in Group A, and all patients had a sudden onset, and the duration was approximately 50 to 60 days in the groups. So the mean angle of deviation was comparable in both the groups, like it was around 34 to 35, and binocular single vision was present only in 25% in both the groups, and stereopsis also only in 25%. We followed up them for the first month, the third month, and the 6th month, and these are the results at 6 months. And in Group A, you can see there was a significant improvement. The success rate was almost 87.5%, and there was no change in Group B. They were persisting with the esotropia, and only 1 patient had a residual in the Botox group, and there was no improvement in Group B. And there was also significant improvement in binocular single vision and stereopsis, and you can see that it improved to 62.5 in group A and 85% of binocular single vision improvement in group A, whereas there was deterioration in group B. So to conclude, we could say that botulinum toxin is quite effective and safe in AACE, and it can be tried not just before planning surgery. That was what we were thinking about earlier, but it was actually a replacement for the surgery, and we have been following up the patients, and except for the single patient, all the other patients were maintaining their correction. Thank you for your patient hearing.
Thank you. Nice presentation.
Have you seen any other recurrence, or in all cases? Like, it is very good because we have also follow up of some cases, but not all cases did improve at first post-op day. Some had residual, and even for some cases we found recurrence also, because when you follow up these children or adults for a period of long time, they eventually deviate, because if they keep on doing again near work, again medial rectus is contracted, so many times we see recurrence. So for a long time, even for some of our patient, after 8-9 months also it recurred. So it is very important to, and one more thing, the BSV you have checked, it is like whether it was checked for near or distance. If you describe in both terms, it is good.
We have checked in both.
Both near and distance.
Deviation was checked for distance and
No,
near?
not deviation, BSV, binocular single vision.
Okay,
so
we
many
have checked only for near.
yeah, so it is always checked, because so many times we'll
And
see for BSV for near.
patients in this group, we have been following up for 1 year, more than 1 year now, and only that single patient had a very actually his deviation was more, and he was the latest, he had more number of days of deviation, and his deviation was also more, and he was the only one whom we had to go for a single muscle surgery, because we gave a second injection, but he was not responding.
Whether you have given in any case bilateral Botox to both medial rectus?
Yes.
Yeah. Okay, thank you.
So I had 2 questions. So the Botox was injected directly or using EMG control? And second, did you get any ptosis or any exodeviations in the early preoperative, early period after the injection?
No, we didn't have any exodeviation, and we saw the patients actually after 2 weeks after injection, and there was no exodeviation, only that residual deviation we had, and it was not it was done directly. We didn't have any EMG.
No ptosis was also seen in any of the patients?
Pardon?
Ptosis?
One patient we had ptosis, mild ptosis, but actually it recovered.
Yeah. And the technique of injection was?
It was 1 centimeter. We just got hold of the muscle and gently we kept it for some time.
It is like without any incision, without any conjunctival.
No incision.
Thank you.
Thank you.
Yeah, next I invite the next speaker to present the case on surgically induced necrotizing scleritis, a nightmare to strabismologist. Dr. Aparna.
Good morning all. I am presenting surgically induced necrotizing scleritis, or SINS, a nightmare to strabismologist. It is a severe inflammation of sclera seen post-operatively with a rapid devastating course leading to visual loss if not recognized timely and treated. These are the 2 main groups of risk factors for the development of SINS. Among the surgeries, pterygium excision and cataract surgery is the most commonly reported. Number of cases reported in case of squint after squint are very less. After the surgical ocular trauma, it can increase the collagenous lytic activity, which can lead to collagen degradation and vascular disruption, which can activate the complement system and can lead to scleral necrosis. Always rule out the main differential diagnosis, that is the postoperative infection. We have a case series of 3 patients. First is a 7-year-old girl with infantile ET. She had a mild developmental delay. Her intraoperative period was very uneventful. Post-operatively, at 1 week, she developed watering, discharge, left eye pain, decreased vision, chemosis, and bulging over the medial rectus and lateral rectus muscle. We started her on IV antibiotics. Her cultures were negative. She showed no improvement. We resorted to IV steroids and topical steroids. She started showing improvement. Her hematological and systemic disease evaluation were all negative. Re-exploration under GA showed choroidal bulge at reinsertion site of lateral rectus. We considered scleral patch, but the patient on subsequent visits showed great improvement. Second is a 63-year-old male, no history of comorbidities. He underwent combined SICS plus squint surgery. On 1 week post-op, he developed severe pain, discharge, defective vision, chemosis, scleral abscess over the medial rectus insertion, and 360-degree choroidal detachment. His culture and sensitivity showed Streptococcus pneumoniae. We thought it as infective and we started him on IV antibiotics, but no response was noted and we resorted to IV steroids followed by tapering oral steroids. He showed drastic improvement. The third case was also a 62-year-old male, hypertensive. He underwent combined phaco plus squint surgery. At 2 weeks of post-op, he also developed the similar complaints as to the previous patient. He also had chemosis, abscess at medial rectus, and 360-degree choroidal detachment. But in his case, at 2 weeks, we noted psoriatic patches over the dorsum of hand. On further history taking, he revealed that he had past history of psoriasis, for which treatment was stopped. So we restarted the psoriasis treatment plus steroid treatment and he showed complete resolution. According to literature, early case reports are seen in patients with multiple surgeries and it is suspected to have underlying immune-mediated process and lateral rectus are commonly involved due to less blood supply. But in our case, all our case reports were in 2 weeks, no history of multiple surgery, and only one of our case had history of autoimmune disease, and all our cases had involvement near medial rectus. Tamhankar et al. Reported atypical necrotizing scleritis in an 88-year-old woman. She also developed over medial rectus with no history of any autoimmune disease. There is no time limit for the development of surgically induced necrotizing scleritis. The longest, even after 51 years, it has been reported. Initial high-dose systemic steroid or pulse therapy followed by maintenance therapy has been proven to the early healing in since, and surgical debridement, contact lens, tectonic scleral patch can be considered in cases when there is no response to steroid therapy. Our case series highlights that early recognition and management of SINS is necessary, and we should always emphasize on the screening of associated systemic diseases in strabismus. Thank you.
Good presentation, doctor. Can you tell me out of how many cases of squint surgeries you got 3 necrotizing scleritis? Means large. How many squint surgeries you usually do? Out of which, how much got this kind
This
of?
is over a period of 14 years, madam.
Oh, okay.
The first case was actually 14 years back it has developed. But I think it is very rare. Maybe I can say 1 in 1,000 or like that only we could get. We could
And
not.
what is your routine of putting steroids after squint surgery? If it is due to large amount of steroids postoperatively, can lead to necrotizing scleritis. How much steroids do you give locally after strabismus surgery?
We usually give weekly tapering dose. We start from 4 times a day. 4, 3, 2, 1 like.
Routine
Routinely
strabismus.
we-
Only 4 times a day.
4 times a day we give.
Okay.
We don't.
Do you think any other intraoperative steps could have led to this, like say excessive cautery or excessive drying up of the sclera?
Actually, in these 3 cases, we haven't used much cautery. Only for the SICS patient at the surgical, not at the site of squint surgery, we have used cautery. So in these 3 cases, we have not used cautery. And
And-
all the intraoperative were similar to all other cases. None was uneventful.
And the post-operative alignment was fine? Or
Patients were actually post-operative alignment was fine.
Thank you. Thank you.
So next. It is. Excuse. That's that.
Possible, and this is a very rare complication.
Yeah, so next speaker is Dr. Kuldeep Kumar Srivastava. He will be presenting on nasal transposition of split tendon lateral rectus muscle for complete third nerve palsy.
Good morning to all of you. Talking about nasal transposition of split tendon lateral rectus muscle for complete third nerve palsy. As you know, complete third nerve palsy is surgical challenge because there is severe impairment of ocular motility. Surgical options are resuscitation of horizontal recti, superior oblique tendon transposition, globe fixation procedure, and recently medial transposition of lateral rectus. And the purpose of this study is to report the results of nasal transposition of split tendon lateral rectus muscle for complete third nerve palsy. It was a retrospective study, 5 eyes of 5 patients, aged between 16 and 30 years, all has large XT and all were emblyopic because I selected those patients only. The surgical technique applied by as described by the Goikit et al. It was 270-degree temporal conjunctival peritomy was done. Lateral rectal muscle was splitted up to the 15 millimeter posterior to insertion. Each half were secured with 5 polyester suture. Superior half passed beneath superior rectus, under the superior rectus and superior oblique, and attached superior border of the medial rectus muscle. And inferior half was passed beneath the inferior rectus, inferior oblique, and attached inferior border of the middle. This is a small video. This is a force reduction test. The inferior rectus muscle being isolated. This is superior rectus muscle. This is lateral rectus muscle, isolated, now being splitted. Now up to 15 millimeter. Now each half is being secured with single arm 5O polyester suture, that's ET bond, being disinserted. Now inferior half is being passed under the inferior oblique muscle. And this is under the inferior rectus muscle. This is under the superior oblique and superior rectus muscle. This is both half are being inserted near the superior and inferior border of the medial rectus muscle. There was 5 patients during the study period. All has split tendon transposition. Pre-op exotropia was more than 50, and post-op deviation was within 20 prism diopter, and no complication like choroid diffusion, RAPD, or optic atrophy was observed. This is 23-year-old female, right third nerve palsy. This is 9-gauge picture, and following surgery, I was up to the 6 month, it was well aligned. Another boy, 16-year-old, right third nerve palsy. This is a 9-gauge picture, and this is the alignment. It was slight hypertrophic, but it was urgently well aligned. So discussion, this procedure was first described by Kaufman in 1991. Later on, it was modified by Goikit in 2013, and various modification has been done, like posterior fixation suture, cross anchoring of the muscles, all these things. But I did congenital cases where I found it difficult to even pull up to the insertion of the medial rectus, so I haven't done all those things. To conclusion, nasal transposition of split tendon muscle is safe and effective for correcting exotropia and third nerve palsy. Thank you very much.
Sir, just one question. In all cases, whether you were able to isolate the lateral rectus easily, or in whether in some case you struggled to, because so many times, sometime we plan, but it is sometime it is difficult to to take the lateral rectus and bring it. So in all,
I was able to isolate. It was difficult to pull actually.
Yeah, difficult to pull.
Some cases, even 1 or 2 millimeter, it became like a hangback.
Yeah.
So sometimes it doesn't reach a jerk because maybe actually acquired cases it might be easier, but I am afraid of diplopia, post-op diplopia. That's why maybe acquired cases lateral rectus may not be that tight, and you can able to reach easily, and even you be make the cross fixation. You can do post fixation sutures, all these things. But I have not attempted acquired one actually because I selected amblyopic patients only.
Yeah, and even NTSLR group itself, they suggest that if you're attaching the split half around 4 to 5 mm away from the medial rectus, then also the results are good.
Yeah, if you are not able to pull up to the there, then you no option actually. You have to do that.
Yeah, no, after pulling, attaching near the, sometime we are not able to attach just near the medial rectus.
Yeah.
So even if you're attaching it away from the medial rectus also, then also results are good. That is the new publication by NTSLR group.
Okay.
Is there any post-operative limitation of movements? Other movements are limited. Is it the muscle is very tight now? So is the eye fixed in a position, or is the movements are possible? Horizontal movements, adduction, abduction.
Well, almost all movements has gone now because
All movements are gone.
Yeah, adduction, elevation, depression was already absent. Now abduction has also gone.
Oh, it's all gone. Okay.
So it's just aim was to just to make eye aligned.
So this surgery is producing a mechanical effect. No, this is just a mechanical effect, not.
It's mechanical because the lateral rectus cannot be trained for the adduction.
Yeah.
So it's just mechanically holding in the primary position and avoiding the drifting of the.
And in all cases, whether you have done inferior oblique recession, PTS, so whether you have done or not, posterior tenectomy of superior oblique, whether you did in any of the case, because we usually, I do in all cases inferior posterior tenectomy of superior oblique.
I went behind the superior oblique and I see that it is free from the. Otherwise, if it will stuck in superior oblique, then muscle will not get reoriented.
No, you have to obviously have to isolate, but tenectomy of superior oblique also helps us to treat whatever the hypertropia,
and I think that may make life easier actually.
Yeah, so that is what is described by Dr. Rohit Saxena.
If you
Even
make tenectomy, probably the passing that superior half becomes easier.
Yes. Even Dr. Gogit, she herself, whenever she talks, she always do PTS. So in all cases, just for that ease.
Okay.
Okay, thank you.
Can I now invite Dr. Aishwarya Kadam to talk to us about squint surgeries, stick or stitch?
So you're not a ratified member, so you will not be eligible for any award.
Good morning, everyone. Myself, Dr. Aishwarya Kadam from Shankarai Hospital, Coimbatore. Today, I'll be presenting on the topic squint surgeries, stick or stitch. Conventionally, in squint surgery, the conjunctiva is opposed with vicral sutures, but suturing is a time-consuming procedure and irritation caused by the sutures is a frequent problem. So fibrin glue is also being used for the same. Fibrin glue works by the combination of two initially separate components, fibrinogen and the thrombin, which activate the final pathway of coagulation cascade. The aim of our study is to compare the outcome of fibrin glue versus vicral suture for conjunctival opposition in strabismus surgery through a periodic follow-up of 6 weeks. The inclusion criteria was patients in between the age group of 5 to 50 years of age with concomitant esotropia or exotropia, undergoing unilateral horizontal squint surgery with limbal conjunctival incision. The exclusion criteria was history of previous eye surgery, trauma to conjunctiva, ocular surface disorders, aged less than 5 years and more than 50 years, patients undergoing vertical muscle surgery, and limbus-based conjunctival incision. The outcome measures were postoperative conjunctival inflammation and wound opposition, postoperative patient comfort with the help of a questionnaire, conjunctival thickness using ASOCT. The participants were recruited to the study by purposive sampling, and allocation to the two groups, that is vicral suture group and fibrin glue group, was made by systematic random sampling with each group containing 32 patients. In the eyes included under vicral suture group, The incised conjunctiva was opposed with 4 or more vicryl sutures, with the loose ends of the suture were cut close to the knot. Whereas in the fibrin glue group, after the muscle surgery was done, the surgical field was meticulously dried and sequential application of fibrin glue to LVH fibrin sealant was done with first for thrombin component followed by fibrinogen component, and the conjunctival tissue was pressed gently over the glue for 3 minutes with the help of 2 forceps. ASOCT, the conjunctival thickness was measured at 3 mm from the scleral spur preoperatively and at 6 weeks postoperatively. Using slit lamp biomicroscopy, conjunctival inflammation in the operated quadrant was graded on day 1, week 2, and week 6 using a modified conjunctival inflammatory index. Signs we looked for were hyperemia, chemosis, and discharge, and they were graded from the scale on a scale from 0 to 3. And wound gaping was also measured if present using a horizontal slit beam in millimeter. With the help of a questionnaire, patients graded the symptoms like pain, redness, irritation, watering, and foreign body sensation, and on all the follow-up visits using a 5-point scale given below. Coming to the results, the difference between the mean symptom score was significant at all 3 points. However, pain was significantly lesser in the fibrin glue group on the immediate post-op day 1. Coming to the signs, the difference between mean sign score was significant only at 2 weeks, with 1 day post-operative signs being present in both the groups, whereas by the end of 6 weeks, no signs being present in both the groups. Only one patient in fibrin glue group of age 8 years developed a conjunctival wound gaping on the temporal quadrant of around 2 mm on postoperative day 1, and which reduced to 1 mm on postoperative 2 weeks and healed completely on its own by end of 6 weeks without any need of suturing. The conjunctival thickness was measured using ASOCT preoperatively and postoperatively at 6 weeks, and was found that thickness increased significantly postoperatively in the suture group as compared to that in the glue group. However, the wound healing clinically, considering signs and symptoms, appeared complete by the end of 6 weeks, but thickness was increased by the end of 6 weeks. Coming to discussion, symptomatically fibrin glue performed better. Pain was significantly less in fibrin glue group on day 1, and no signs were present by the end of 6 weeks. Our results were in relation with other studies conducted by Lee J.H. et al., Dadia S. et al., Biedner et al. However, Basmak et al. Had no difference between fibrin glue group and suture group by the end of 2 weeks. Dadia et al. Conducted a similar study in 2001 and found that discomfort and excessive watering of eyes was reported in almost 42% of the patients who were closed with fibrin glue, closed with the suture, and none of the study participants in our study had any gaping by the end of 6 weeks. Dadia et al. Reported that 4 out of 19 eyes closed with fibrin glue developed exposure and needed suturing. Tips to have a good conjunctival wound apposition and lesser risk of conjunctival wound retraction postoperatively are proper excision of excessive tenons fascia, application of gentle pressure over the reposited conjunctiva after application of glue for minimum of 3 minutes for firm adhesion, and application of an eye patch or bandage at least 1 day postoperatively, and careful removal of the eye patch on day 1 of surgery. We infer that age has no influence on conjunctival wound healing or healing time after surgery in either groups. Above results were found similar to Erbakshi et al., who found no difference between thin atrophic conjunctival wounds of adult patients and thick pulpy conjunctival wounds of pediatric patients. However, Krihok et al. Found that fibrin glue was more effective in thin atrophic conjunctiva in adults. Coming to role of ASOCT in our study, the conjunctival thickness was used as a measure for inflammation and wound healing. The thicker the conjunctiva, the more the underlying inflammation, and thus delayed is the wound healing. Both the groups performed equally by the end of 6 weeks in relation to clinical measures of signs and symptoms, where we noticed that the clinical features had reduced in both the groups by the end of 6 weeks. However, thickness increased significantly in vicryl suture group as compared to that in the fibrin glue group. This indicates that even though the patients were asymptomatic and the conjunctival healing appeared to be complete on slit lamp examination, inflammation and wound healing continues to occur underneath the conjunctival surface in both the groups, more so in suture group.
Dr. Aishwarya, your time is up. 6 minutes are up actually. Okay, you can just continue.
Yeah. In conclusion, our results state that use of fibrin glue reduces early postoperative pain and postoperative inflammation and eventually provides a more comfortable course of conjunctival closure after strabismus surgery. Hence, it can be considered as an alternative vicral suture in absence of cost constraints. Thank you so much.
Just one question. In all cases where you use the glue, did you patch the eye?
Yes, ma'am.
So if you're doing a bilateral surgery,
No, ma'am. We all cases were
so
unilateral.
can you advise it for bilateral surgery?
No, ma'am.
Only that. Okay. And what about the cost factor? Which one is costlier, the glue or the suture?
Glue is costlier, ma'am.
By how
but,
much? By how much?
Actually, we didn't consider that in our studies. Cost factor was not considered.
Release is available for 4,000 and 3,500. Can be used actually in only cases. Can use it for almost 3 cases.
Thank you so much.
Dr. Mahima is not here, right? Dr. Ayushi is also not there. Is Dr. Shreya Shah here?
She's not here. No, she's not here.
Dr. Bhavna Piplani?
Shakshi.
You're Dr. Bhavna, right? Yes, please come. So she's going to talk to us about superior oblique palsy, 10 things to learn from 10 cases.
Good morning, everyone. I'll be speaking on superior oblique palsy, lessons learned from 10 cases. Lesson number 1, most cases are congenital in origin. Congenital idiopathic are the most frequent etiologies. There's a history of early onset with facial asymmetry, long-standing head tilt with photographic evidence, large vertical fusional amplitudes, no diplopia, and lack of subjective symptoms of torsion. Lesson number 2 is the spread of comitance, which is seen in some long-standing cases where the hypertropia may be equal in the different positions of gaze because of contraction of the ipsilateral antagonist, the overaction of the contralateral yoke muscle, and secondary inhibitional palsy appears to be secondary inhibitional palsy of the contralateral antagonist. Lesson number 3, fundus extortion might not always be present in the paretic eye. Studies have found approximately 25% of patients with unilateral superior oblique palsy had excyclotorsion in the non-paretic eye due to fixation preference and neural adaptation. The paretic dominant eye could influence alignment of the non-paretic eye through conjugate cycloversion eye movements. So prolonged fixation with the paretic dominant eye might act to decrease extortion, which induces extortion in the non-paretic eye through the Hering's law. Lesson number 4, coexisting horizontal vertical deviation may be present in around 50% cases of superior oblique palsy. Horizontal deviation of 8 PD or more might need horizontal muscle surgery in addition to vertical muscle surgery. For example, in this case of a left congenital superior oblique palsy with inferior oblique overaction grade 3 and large angle alternating exotropia, he underwent horizontal muscle surgery in the form, he had 70 PD XT horizontal deviation, grade 3 inferior oblique overaction and fundus extortion grade 2. The patient underwent supramaximal horizontal muscle surgery to tackle horizontal and vertical deviation in one go. So OSLR recession 12 mm, OSMR resec 7 mm and OSIO recession 10 mm was done. At 2 years follow-up, this patient is ortho in primary position and OSIO overaction has completely resolved. Lesson number 5, small horizontal deviations may self-correct with the vertical muscle surgery. So horizontal rectus muscle surgery is only needed in deviations more than 15 PD, which has been observed clinically, since most of the less severe cases may resolve with surgery only involving the cyclovertical muscles. This patient with the right congenital superior oblique palsy, a large angle vertical deviation of 35 PD R by L, and a horizontal deviation of 16 PD ET was present. The patient underwent right anterior nasal transpositioning of inferior oblique. This is at 3 months follow-up. The patient is ortho in primary position, does not have a significant horizontal deviation, which has reduced to about 4 to 6 PD, and IO overaction has resolved. Lesson number 6, horizontal near distance disparity matters even in vertical deviation, so that needs to be taken into account. This patient with a left congenital superior oblique palsy with exotropia near more than distance, and L by R in primary position, maximum deviation in the dextro version. So horizontal near distance disparity is an important measurement even in vertical deviations, where we need to target the maximum horizontal deviation, which was near deviation in this case of divergence insufficiency type of exotropia. So it is important to do the horizontal and vertical deviation neutralization in all 9 diagnostic positions of gaze, and for near and for distance. So this particular patient underwent LR recession 6 mm, MR resection 4.5 mm, and IO recession 8 mm. At 2.5 years follow-up, this patient is maintaining ortho. Lesson number 7, single muscle surgery might suffice in a lot of cases. It may be successful irrespective of angle of deviation, even in large vertical deviations. So it might be better to operate on only one muscle at a time to ascertain the effect this will have on the ocular motility pattern. Studies have shown that in majority cases, one muscle surgery is sufficient. We allow time to the patient to adapt to the resulting ocular motility and to utilize their extended vertical fusion. But it is important that the patient should be aware that further surgery may be needed. This patient with a left congenital superior oblique palsy with exotropia with DVD, PBCT 55PD XT and 16PD LHT underwent single muscle surgery for the vertical deviation, anterior transpositioning of inferior oblique along with horizontal muscle surgery. Lesson number 8, inferior oblique weakening might work most of the time. It has been widely considered as the first surgical option in the treatment of symptomatic SO palsy. So IO surgery in the form of graded recession, ATIO, ANTIO, IO myectomy might be considered, especially in cases where there is absence of excessive SO tendon laxity confirmed on Guyton's exaggerated FTT. It is effective in alleviation of ocular deviation and abnormal head posture while avoiding adverse effects that can happen with other forms of strabismus surgery such as iatrogenic Brown syndrome and overcorrection. This patient with a congenital SO palsy in the left eye with large angle exotropia with grade 3 eye overreaction underwent OS-IO recession 10 mm along with horizontal muscle surgery. Lesson number 9, look out for masked bilateral superior oblique palsy. Bilateral congenital superior oblique palsy may be overlooked in children in spite of detailed preoperative evaluation, and masked bilaterality should always be kept in mind in cases with unilateral pathology, and patients should be informed about the possibility of bilaterality that might get unmasked in the postoperative period. This patient is a case of bilateral congenital masked superior oblique palsy, the pre-op and the 6 months post-op photograph. So this patient underwent bilateral anterior nasal transpositioning of inferior oblique. The eye overaction has resolved and the V pattern has collapsed. Lesson number 10, anterior nasal transpositioning of inferior oblique works well for large angles and coexisting DVD. We have seen great results in large angle SOPs, SOP with DVD, SOP with missing tendons. Unilateral ANTIO is said to induce asymmetry in upgaze due to anti-elevation syndrome and fullness of the lower lid. But in our experience, even unilateral ANTIO worked well without any of the above drawbacks. This is the case of left congenital superior oblique palsy with DVD with infantile residual esotropia, underwent OS ANTIO along with horizontal muscle surgery, and is maintaining ortho at 3 years follow-up. Thank you.
Thank you. Only for the case 4, I think the case 4th was esotropia, minimal esotropia. So usually in cases of bilateral superior oblique palsy, it may be like undiagnosed bilateral, because in those cases only you will see V pattern esotropia in down and primary. Down may be minimal esophoria in primary position, it could be minimal ET, and in up gaze there will be mild XT. So you will feel like that angle is very less, and that's because angle is very whenever you tackle inferior oblique bilateral, obviously the deviation will go. So usually those cases are more associated with bilateral, and always you have to check for all 9 cases and reversal that you have not mentioned, that in head tilt you have to always see whether there is any reversal of R by L or L by R. That is very important.
Thank you.
Thank you. Can I call upon Dr. Sakshi Lalwani? She is not here. Absent? Yeah. So, session. Okay. So, thank you to all the presenters.